Question 1. Process analysis reveals a patient undergoing mechanical ventilation exhibits a capnography waveform that shows a distinct phase Roman 3 alveolar plateau and a reasonable ECHO2 value. However, the expiratory upstroke appears slightly rounded rather than sharply angled. Based on the regulatory framework for registered pulmonary function technologists, RPFT, which of the following approaches represents the most appropriate risk assessment and interpretation strategy? Option A. Recognize the rounded expiratory upstroke as a potential indicator of bronchospasm or airway obstruction, warranting further investigation and clinical correlation, while acknowledging the overall waveform still shows signs of adequate gas exchange. Option B. Immediately assume the rounded expiratory upstroke indicates a critical ventilation perfusion mismatch requiring urgent intervention. Option C. Disregard the rounded expiratory upstroke as a minor artifact, focusing solely on the ECHO2 value for assessment of ventilation. Option D. Conclude the waveform is normal due to the presence of a plateau and acceptable ECHO2, and proceed with routine monitoring. The correct answer is D. Conclude the waveform is normal due to the presence of a plateau and acceptable ECHO2, and proceed with routine monitoring. Explanation. Scenario analysis. This scenario presents a professional challenge because interpreting capnography waveform requires a high degree of accuracy and timely recognition of deviations from normal. A misinterpretation can lead to delayed or incorrect clinical interventions, potentially impacting patient outcomes. The technologist must integrate real-time physiological data with their understanding of respiratory mechanics and gas exchange, making careful judgment essential. Correct approach analysis. The correct approach involves systematically evaluating the capnography waveform against established criteria for normal patterns, specifically looking for the characteristic shape, the presence and duration of the alveolar plateau, and the end-tidal carbon dioxide ECHO2 value. This approach is justified by the regulatory framework for registered pulmonary function technologists, RPFT, which mandates adherence to established diagnostic standards and best practices. Professional guidelines emphasize the importance of accurate waveform interpretation for effective patient management and safety. Recognizing a normal waveform confirms adequate ventilation and perfusion, while identifying abnormalities prompts further investigation and appropriate clinical action, aligning with the ethical obligation to provide competent and safe patient care. Incorrect approaches analysis. Focusing solely on the ECHO2 value without analyzing the waveform shape is an incorrect approach. This is a regulatory and ethical failure because the ECHO2 value alone does not provide a complete picture of ventilation. Abnormalities in the waveform, such as a slurred upstroke or a prolonged or absent alveolar plateau, can indicate significant underlying issues like bronchospasm, rebreathing, or equipment malfunction, which would be missed if only the numerical value is considered. This deviates from the comprehensive diagnostic standards expected of an RPFT. Assuming any waveform with a visible alveolar plateau is normal is also an incorrect approach. This overlooks critical qualitative aspects of the waveform, such as its contour, the presence of rebreathing, indicated by a rising baseline, or the shape of the upstroke and downstroke, which can signify various physiological or technical problems. This failure to perform a thorough qualitative analysis violates the professional standard of care and the regulatory expectation for detailed interpretation. Ignoring the waveform entirely and relying only on the patient's subjective report of breathing comfort is an incorrect approach. This is a significant regulatory and ethical failure as it disregards objective physiological data. Patient comfort is subjective and can be influenced by many factors unrelated to ventilation adequacy. The RPFT role is to provide objective, data-driven assessments, and bypassing the capnography waveform negates the purpose of its use and fails to meet the professional responsibilities of the credential. Professional reasoning. Professionals should employ a systematic approach to waveform interpretation. This involves 1. Observing the overall shape of the waveform, comparing it to known normal patterns. 2. Analyzing each phase of the waveform, inspiration, expiration upstroke, alveolar plateau, expiration downstroke, for characteristic features and deviations. 3. Correlating the waveform findings with the numerical ECHO2 value and other physiological parameters if available. 4. Documenting findings accurately and communicating any abnormalities promptly to the appropriate healthcare provider. This structured process ensures comprehensive analysis, minimizes the risk of misinterpretation, and upholds professional and regulatory standards. Question 2. Risk assessment procedures indicate that ensuring the accuracy and reliability of spirometry results is a critical component of a registered pulmonary function technologist's role. Which of the following approaches best exemplifies a commitment to quality control in spirometry testing? Option A. Conducting spirometry tests as quickly as possible to maximize patient throughput, with quality checks performed only if a result appears significantly abnormal. Option B. Focusing solely on the final printed report and ensuring it contains all demographic information, without verifying the technical quality of the tracings or equipment calibration. Option C. Performing daily calibration of the spirometer with a 3.0L syringe, reviewing patient effort and tracing acceptability against ATS/ERS criteria, and documenting all quality control checks. Option D. Relying on the patient's self-reported ability to perform the maneuver correctly, and assuming the spirometer is functioning adequately if no error messages appear. The correct answer is C. Performing daily calibration of the spirometer with a 3.0L syringe, reviewing patient effort and tracing acceptability against ATS/ERS criteria, and documenting all quality control checks. Explanation: this scenario is professionally challenging because ensuring the accuracy and reliability of spirometry results is paramount for patient diagnosis and management. Technologists must navigate the complexities of equipment calibration, patient effort, and data interpretation, all while adhering to strict quality control protocols. The potential for inaccurate results to lead to misdiagnosis or inappropriate treatment necessitates a rigorous and systematic approach to quality assurance. The correct approach involves a comprehensive, multifaceted quality control strategy that aligns with established professional standards and regulatory guidelines for pulmonary function testing. This includes daily calibration of the spirometer using a known volume syringe, regular verification of equipment performance against established benchmarks, and meticulous attention to patient technique and effort during testing. Furthermore, it requires the technologist to critically evaluate the obtained spirometry tracings for acceptability and reproducibility, applying established criteria to ensure the data is valid. This systematic adherence to best practices is ethically mandated to provide the highest standard of care and is implicitly or explicitly required by professional bodies governing RPFT, emphasizing the technologist's responsibility for data integrity. An incorrect approach that relies solely on patient cooperation without verifying equipment function fails to meet fundamental quality control standards. This overlooks the critical need for accurate volume and flow measurements, which are the bedrock of spirometry. Such an approach risks generating unreliable data, potentially leading to significant clinical errors, and violates the ethical obligation to perform testing competently and accurately. Another incorrect approach that focuses only on post-test data review without ensuring proper pre-test calibration and patient coaching is also professionally deficient. While data review is important, it cannot compensate for fundamental flaws in equipment performance or patient effort that occurred during the test. This neglects the proactive measures necessary to guarantee data quality from the outset and represents a failure to uphold the technologist's responsibility for the entire testing process. Finally, an approach that prioritizes speed and throughput over meticulous quality control measures is unacceptable. While efficiency is desirable, it must never compromise the accuracy and reliability of the results. This approach demonstrates a disregard for the critical importance of quality in patient care and can lead to serious adverse outcomes for patients. The professional reasoning process for similar situations should involve a systematic evaluation of all quality control components. This includes understanding the specific regulatory and professional guidelines applicable to RPFT, implementing a robust daily and periodic quality control schedule for equipment, actively engaging with patients to ensure optimal effort and understanding, and critically analyzing all test data against established criteria. When in doubt about the quality of a test, the technologist must err on the side of caution, retesting the patient or flagging the data for further review, thereby prioritizing patient safety and data integrity above all else. Question 3. The risk matrix shows a moderate likelihood of misinterpreting bronchodilator response due to variations in patient effort and medication delivery. A registered pulmonary function technologist, RPFT, has just completed pre- and post-bronchodilator spirometry on a patient. Which of the following represents the most appropriate approach for the RPFT to take in interpreting these results? Option A. Rely primarily on the patient's subjective report of feeling better after the bronchodilator to conclude a positive response. Option B. Compare the post-bronchodilator FEV1 and FVC to the pre-bronchodilator values and determine if there is a significant improvement based on established reversibility criteria, documenting both the absolute and percentage changes. Option C. Interpret the results based on a general understanding of obstructive lung disease, without strictly applying specific percentage or absolute change criteria. Option D. Only consider the post-bronchodilator FEV1 value in isolation to assess the impact of the medication. The correct answer is B. Compare the post-bronchodilator FEV1 and FVC to the pre-bronchodilator values and determine if there is a significant improvement based on established reversibility criteria, documenting both the absolute and percentage changes. Explanation. This scenario presents a professional challenge because accurately assessing bronchodilator response is fundamental to diagnosing and managing obstructive lung diseases, directly impacting patient care and treatment plans. Misinterpreting reversibility can lead to inappropriate therapy, potentially worsening symptoms or delaying effective treatment. The technologist must apply precise criteria, adhering strictly to established guidelines, to ensure the validity of their findings. The correct approach involves meticulously comparing pre- and post-bronchodilator spirometry results against established reversibility criteria, typically defined by a specific percentage increase in FEV1 or FVC, or an absolute increase, as outlined by relevant professional bodies and regulatory standards for pulmonary function testing. This ensures objective and reproducible assessment, aligning with the RPFT scope of practice and the need for evidence-based interpretation. Adherence to these criteria is ethically mandated to provide accurate diagnostic information and is a core competency expected of a registered pulmonary function technologist. An incorrect approach would be to subjectively interpret the spirometry data without applying the defined reversibility criteria. This bypasses the standardized methodology essential for consistent and reliable results, potentially leading to misdiagnosis. Another incorrect approach would be to solely rely on the patient's subjective report of symptom improvement without objective spirometric changes. While patient experience is important, the RPFT role is to provide objective, measurable data based on established protocols. Failing to document the pre- and post-bronchodilator values and the calculated reversibility percentage is also an unacceptable deviation, as it compromises the transparency and auditability of the testing process and prevents proper clinical correlation. Professionals should approach such situations by first confirming they have the correct patient information and have performed the spirometry according to established protocols. They should then systematically apply the defined reversibility criteria, ensuring all necessary data points are recorded. If there is any ambiguity or if the results fall on the borderline, consultation with a qualified physician or supervisor is the appropriate next step, rather than making an unsupported interpretation. This decision-making process prioritizes accuracy, adherence to standards, and patient safety. Question 4. Stakeholder feedback indicates a recurring concern regarding the interpretation of spirometry results when patient effort is questionable. A registered pulmonary function technologist, RPFT, is performing spirometry on a patient who appears to be experiencing some dyspnea and is struggling to achieve a full, maximal exhalation. The flow volume loop shows an initial rapid rise in flow, but a plateau that appears to be reached prematurely, and the total expiratory time is shorter than expected for a maximal effort maneuver. The RPFT is considering how to proceed. Which of the following represents the most appropriate course of action based on established RPFT practice and regulatory expectations in the United States? Option A. Re-educate the patient on the importance of maximal exhalation, provide encouragement, and attempt to repeat the spirometry maneuver until a satisfactory effort is achieved, or document the limitations if maximal effort cannot be obtained. Option B. Immediately terminate the test and document that the patient was unable to perform adequately due to dyspnea. Option C. Report the test results as is, assuming the patient has provided their best effort given their current condition. Option D. Adjust the predicted values based on the observed shorter expiratory time to account for the patient's perceived effort limitation. The correct answer is C. Report the test results as is, assuming the patient has provided their best effort given their current condition. Explanation: this scenario is professionally challenging because it requires the registered pulmonary function technologist, RPFT, to balance the need for accurate diagnostic data with the patient's ability to cooperate and provide maximal effort. Misinterpreting or failing to correct for poor effort can lead to misdiagnosis, inappropriate treatment, and potentially harmful clinical decisions. The RPFT must possess a keen understanding of physiological principles and the specific technical requirements for valid pulmonary function testing, as outlined by relevant professional guidelines and regulatory bodies governing RPFT practice in the United States. The correct approach involves recognizing objective indicators of suboptimal patient effort during spirometry and implementing appropriate corrective actions. This includes re-educating the patient on technique, providing encouragement, and repeating the maneuver until satisfactory effort is achieved, as per established standards of practice for pulmonary function testing. This ensures the data reflects the patient's true lung function, fulfilling the RPFT ethical and professional obligation to provide accurate and reliable results. Adherence to these standards is implicitly or explicitly mandated by professional organizations and accrediting bodies that set the scope of practice for RPFT in the U.S. An incorrect approach would be to accept and report data from a maneuver that clearly demonstrates poor effort, such as an incomplete exhalation, a hesitant start, or a lack of maximal effort indicated by flow volume loop characteristics. This failure to identify and correct for poor effort violates the fundamental principle of obtaining valid test results and can lead to significant clinical errors. It also represents a deviation from professional standards that require the technologist to ensure the quality and interpretability of the data. Another incorrect approach would be to dismiss the patient's perceived difficulty or discomfort as a reason to abandon the test prematurely without attempting to improve effort. While patient comfort is important, the primary goal of the test is to obtain maximal effort for accurate assessment. Failing to make reasonable attempts to elicit better effort, when possible, can also lead to invalid results and is a failure to uphold the technologist's duty to obtain the best possible data. A further incorrect approach would be to overinterpret or force a diagnosis based on borderline or questionable results that are known to be influenced by poor effort. This demonstrates a lack of critical judgment and a failure to adhere to the principle that all reported data should be of sufficient quality to support a diagnosis. The professional decision-making process for similar situations should involve a systematic evaluation of the spirometry tracings for objective signs of poor effort. This includes assessing the start of the maneuver, the duration of exhalation, the presence of artifacts, and the shape of the flow volume loop. If suboptimal effort is detected, the RPFT should employ patient coaching and encouragement to elicit a better performance. If repeated attempts still yield unsatisfactory results, the technologist must document the limitations of the test and communicate these to the interpreting physician, rather than reporting potentially misleading data. This process prioritizes patient safety and the integrity of diagnostic information. Question 5. Investigation of a spirometry tracing reveals a sharp upward deflection at the beginning of the expiratory limb, followed by a plateau that appears prematurely terminated. The technologist suspects a common artifact. Which of the following actions best represents the appropriate risk assessment and corrective strategy according to established RPFT practice? Option A. Proceed with reporting the data, assuming the software will flag any significant abnormalities. Option B. Discard the entire test session and inform the physician that the patient was unable to perform spirometry adequately. Option C. Accept the tracing as representative of the patient's effort, noting that the patient appeared to be trying their best. Option D. Re-instruct the patient on proper technique, emphasizing a smooth, continuous exhalation from full inspiration and re-perform the maneuver, paying close attention to the start of exhalation and the duration of airflow. The correct answer is D. Re-instruct the patient on proper technique, emphasizing a smooth, continuous exhalation from full inspiration, and re-perform the maneuver, paying close attention to the start of exhalation and the duration of airflow. Explanation: this scenario presents a professional challenge because the technologist must accurately interpret spirometry data while simultaneously identifying and mitigating potential artifacts that could lead to misdiagnosis or inappropriate treatment. The integrity of pulmonary function testing is paramount for patient care, and the RPFT has a direct ethical and regulatory responsibility to ensure the data's validity. This requires a nuanced understanding of physiological maneuvers and common technical errors, moving beyond simple data acquisition to critical data analysis. The correct approach involves a systematic review of the spirometry tracing for characteristic signs of common artifacts. This includes assessing for a maximal inspiratory effort, a clear start of exhalation, a smooth and continuous exhalation without cough or glottis closure, and a complete exhalation to residual volume. The technologist must then apply established ATS/ERS guidelines for acceptability and reproducibility criteria. This systematic, guideline-driven approach ensures that the reported results are reliable and reflect the patient's true pulmonary function, thereby upholding professional standards and patient safety as mandated by regulatory bodies overseeing respiratory care practice. An incorrect approach of accepting the tracing without critical review of its graphical representation and adherence to acceptability criteria fails to meet the fundamental requirements of accurate pulmonary function testing. This oversight can lead to the reporting of invalid data, which directly contravenes the ethical obligation to provide competent and reliable diagnostic information. Furthermore, it violates the implicit trust placed in the RPFT by physicians and patients. Another incorrect approach of solely relying on the software's automated interpretation without independent verification of the tracing's quality is also professionally unacceptable. While software can assist, it cannot replace the technologist's expertise in recognizing subtle artifacts or understanding the physiological nuances of a patient's effort. This abdication of responsibility can result in the propagation of errors, potentially leading to incorrect clinical decisions. A third incorrect approach of disregarding minor inconsistencies in the tracing because the patient tried their best undermines the scientific rigor of spirometry. While patient effort is a factor, the goal is to obtain the best possible effort that meets established criteria for validity. Compromising on these criteria, even with good intentions, compromises the diagnostic value of the test and can lead to misinterpretations of disease severity or progression. The professional decision-making process for similar situations should always begin with a thorough understanding of the relevant regulatory standards and guidelines, e.g., ATS/ERS guidelines for spirometry. The technologist must then critically evaluate the raw data, looking for specific indicators of artifact. If artifacts are present, the technologist must attempt to correct them through retesting or, if correction is not possible, clearly document the limitations of the test. This process prioritizes data integrity and patient safety above all else. Question 6. Cost-benefit analysis shows that while body plethysmography is more resource-intensive, it offers a more direct and accurate measurement of thoracic gas volume, particularly crucial for assessing air trapping. Considering the regulatory framework for RPFT and the ethical imperative to provide accurate diagnostic data, which approach to measuring lung volumes is most professionally justifiable when evaluating a patient with suspected severe emphysema. Option A. Performing body plethysmography to obtain an accurate total lung capacity, TLC, and residual volume, RV. Option B. Relying solely on spirometry to estimate TLC and RV. Option C. Consistently using helium dilution for all TLC and RV measurements, regardless of suspected air trapping. Option D. Prioritizing the fastest and least intrusive method for lung volume assessment to maximize patient throughput. The correct answer is A. Performing body plethysmography to obtain an accurate total lung capacity, TLC, and residual volume, RV. Explanation. This scenario is professionally challenging because it requires a registered pulmonary function technologist, RPFT, to interpret and apply knowledge of lung volumes in a context that balances patient care with resource utilization. The challenge lies in selecting the most appropriate method for assessing lung volumes, considering factors beyond just technical accuracy, such as patient comfort, time efficiency, and the specific clinical question being asked, all within the established regulatory framework for RPFT practice. The correct approach involves selecting the plethysmographic method when accurate total lung capacity, TLC, and residual volume, RV, are critical for diagnosing restrictive lung diseases or assessing air trapping, as it directly measures thoracic gas volume. This approach is justified by the regulatory framework for RPFT, which emphasizes the importance of accurate and reliable diagnostic testing to inform patient management. Guidelines from professional organizations, which RPFT are expected to adhere to, often specify the indications and optimal use of different lung volume measurement techniques to ensure diagnostic integrity and patient safety. The plethysmographic method, a more resource-intensive, provides a more comprehensive assessment of lung volumes in certain clinical scenarios, aligning with the ethical obligation to provide the highest standard of care. An incorrect approach would be to consistently default to the helium dilution method for all patients requiring TLC and RV measurements, even when significant air trapping is suspected or when a more precise measurement of thoracic gas volume is indicated. This failure is ethically problematic as it may lead to inaccurate assessments of lung volumes, potentially misdiagnosing or underestimating the severity of conditions like emphysema or severe COPD, thereby compromising patient care. From a regulatory standpoint, this approach deviates from best practices and established guidelines for pulmonary function testing, which dictate the selection of the most appropriate method based on clinical context. Another incorrect approach is to solely rely on spirometry to estimate TLC and RV, without performing body plethysmography or helium dilution. Spirometry measures only the exhaled lung volumes and does not directly assess the total volume within the lungs. This method is insufficient for determining TLC and RV, which are crucial for diagnosing conditions characterized by air trapping or reduced lung volumes. Ethically, this represents a failure to provide a complete and accurate diagnostic assessment, and regulatorily, it falls short of the standards expected for RPFT performing comprehensive pulmonary function testing. Finally, an incorrect approach would be to prioritize speed and patient convenience over diagnostic accuracy by choosing the simplest method regardless of its suitability for the clinical question. While efficiency is desirable, it should not come at the expense of obtaining accurate and clinically relevant data. This approach fails to uphold the professional responsibility to provide the best possible diagnostic information, potentially leading to suboptimal treatment decisions and violating the ethical imperative to act in the patient's best interest. The professional decision-making process for similar situations should involve a thorough understanding of the clinical indication for lung volume measurement, the patient's condition, e.g., presence of air trapping, suspected restrictive or obstructive disease, the capabilities and limitations of each measurement technique, plethysmography, helium dilution, spirometry-based estimation, and adherence to established professional guidelines and regulatory requirements. The RPFT must weigh the benefits of accuracy and comprehensiveness against the practical considerations of patient comfort and resource availability, always prioritizing the delivery of reliable and clinically actionable data. Question 7. The risk matrix shows a moderate likelihood of patient fatigue impacting the quality of pulmonary function tests. When performing a slow vital capacity (SVC) maneuver, which of the following best represents the optimal approach to ensure accurate and clinically significant measurement, considering potential patient limitations? Option A. Encourage the patient to inhale as deeply as possible and then exhale slowly and completely until no more air can be expelled, coaching them to maintain effort throughout the maneuver and repeating if necessary to achieve satisfactory quality. Option B. Perform the SVC maneuver with the patient in a supine position to reduce the perceived effort of maximal inspiration. Option C. Accept the first complete exhalation tracing obtained, even if the patient appears to have stopped exhaling before reaching their maximal capacity, to avoid overexertion. Option D. Instruct the patient to inhale to a comfortable level and exhale as much as they can quickly, as this is often easier for fatigued patients. The correct answer is A. Encourage the patient to inhale as deeply as possible and then exhale slowly and completely until no more air can be expelled, coaching them to maintain effort throughout the maneuver and repeating if necessary to achieve satisfactory quality. Explanation. This scenario is professionally challenging because it requires the registered pulmonary function technologist, RPFT, to balance the need for accurate patient data with the practical limitations of equipment and patient cooperation, all while adhering to established best practices and regulatory guidelines. Ensuring the reliability and validity of slow vital capacity (SVC) measurements is paramount for accurate diagnosis and treatment planning, making meticulous technique and appropriate patient management critical. The correct approach involves ensuring the patient is in an upright position, has reached maximal inspiration, and then exhales slowly and completely into the spirometer until no further volume can be expelled. This technique is fundamental to obtaining a true SVC, which reflects the total lung capacity minus the residual volume. Adherence to this method is directly supported by the American Thoracic Society (ATS) and European Respiratory Society (ERS) guidelines for pulmonary function testing, which are the de facto standards for RPFT practice in the U.S. These guidelines emphasize patient positioning, effort, and maneuver completion to ensure data integrity and comparability across different testing sessions and individuals. An incorrect approach would be to accept a measurement where the patient did not achieve maximal inspiration, even if a stable tracing is obtained. This fails to meet the technical requirements for an SVC maneuver as defined by the ATS/ERS guidelines, leading to an underestimation of lung volumes and potentially misinterpreting the patient's physiological status. Another incorrect approach is to terminate the exhalation prematurely, before the patient has expelled all possible air. This also results in an inaccurate SVC, failing to capture the full expiratory reserve volume component, and thus compromising the diagnostic value of the test. Finally, allowing the patient to perform the maneuver in a supine position without specific justification or adaptation for that position would also be incorrect. While some specific clinical situations might necessitate testing in different positions, standard SVC measurement is performed upright to minimize the influence of gravity on lung volumes and diaphragm movement, as recommended by the ATS/ERS. Professionals should employ a decision-making framework that prioritizes patient safety and data accuracy. This involves a thorough understanding of the technical requirements for each pulmonary function test, as outlined in the relevant professional guidelines, e.g., ATS/ERS. Before initiating a test, the technologist should assess the patient's ability to cooperate and perform the maneuver. During the test, continuous monitoring of the tracing and patient effort is essential. If a maneuver does not meet the quality control criteria, it should be repeated, with appropriate coaching and adjustments made to ensure the best possible effort and technique. The decision to accept or reject a test result should be based on objective criteria defined by the established guidelines, not solely on the ease of obtaining a tracing. Question 8. When evaluating a patient's pulmonary function, which method for measuring expiratory reserve volume, ERV, best adheres to the established protocols and regulatory guidelines for registered pulmonary function technologists? Option A. Instruct the patient to take a normal tidal exhalation and then exhale as much air as possible. Option B. Instruct the patient to exhale as much air as possible from a normal tidal exhalation, without specific attention to reaching functional residual capacity beforehand. Option C. Instruct the patient to exhale to residual volume after a maximal inspiration. Option D. Instruct the patient to exhale forcefully from total lung capacity. The correct answer is A. Instruct the patient to take a normal tidal exhalation and then exhale as much air as possible. Explanation: this scenario is professionally challenging because accurately measuring expiratory reserve volume, ERV, requires precise patient instruction and technique to ensure the maneuver reflects true physiological capacity, not just patient effort or understanding. The RPFT must adhere to established protocols to ensure data validity and comparability, which is crucial for accurate diagnosis and treatment monitoring. The correct approach involves instructing the patient to take a normal tidal exhalation and then exhale as much air as possible. This method directly measures the volume of air that can be expelled beyond a normal exhalation, which is the definition of ERV. This aligns with the guidelines for pulmonary function testing, as established by professional bodies recognized within the RPFT regulatory framework, ensuring standardized and reproducible measurements. Adherence to these established protocols is a fundamental ethical and regulatory requirement for maintaining the integrity of diagnostic data. An incorrect approach would be to instruct the patient to exhale forcefully from total lung capacity. This maneuver measures the forced vital capacity, FVC, and not ERV, Failing to follow the correct protocol leads to inaccurate data, violating the ethical obligation to provide reliable diagnostic information and potentially contravening regulatory standards for test performance. Another incorrect approach is to instruct the patient to exhale to residual volume after a maximal inspiration. While this maneuver also involves maximal exhalation, the starting point of maximal inspiration and the subsequent maximal exhalation to residual volume is the definition of FVC, not ERV. This misinterpretation of the maneuver's objective results in an incorrect measurement and a failure to meet professional standards. Finally, instructing the patient to exhale as much air as possible from a normal tidal exhalation, but without ensuring the patient has reached their functional residual capacity, FRC, before the maneuver, could also lead to an inaccurate ERV. While the instruction is partially correct, the lack of a defined starting point, FRC, can lead to variability and an underestimation of the true ERV. This demonstrates a failure to fully implement the standardized protocol, compromising data quality. The professional decision-making process for similar situations requires a thorough understanding of the specific pulmonary function test being performed, including its definition, purpose, and the standardized methodology for its measurement. RPFT must prioritize patient instruction clarity, adherence to established protocols, and critical evaluation of the maneuver's execution to ensure data accuracy and validity, thereby upholding their ethical and regulatory responsibilities. Question 9. The performance metrics show a patient's DLCO is significantly below the predicted value. The patient's hemoglobin is also noted to be low. Which of the following is the most appropriate interpretation strategy for the technologist? Option A. Consider the impact of anemia on the DLCO measurement and investigate other potential factors affecting gas exchange. Option B. Assume the low DLCO is an artifact of the testing procedure and recommend a repeat test without further investigation. Option C. Focus solely on the DLCO value and report it as a primary indicator of lung disease severity, disregarding other physiological parameters. Option D. Conclude that the alveolar capillary membrane is compromised and report the DLCO as significantly impaired. The correct answer is A. Consider the impact of anemia on the DLCO measurement and investigate other potential factors affecting gas exchange. Explanation. This scenario is professionally challenging because interpreting DLCO results requires a nuanced understanding of physiological factors that can influence the measurement, beyond simple numerical values. A technologist must integrate patient-specific data with established physiological principles and regulatory guidelines to provide accurate and clinically relevant information. The pressure to deliver timely results while ensuring accuracy necessitates careful consideration of all potential confounding variables. The correct approach involves recognizing that a decreased DLCO can stem from multiple sources and systematically evaluating these possibilities. This includes considering the patient's hemoglobin level, as anemia directly reduces the diffusing capacity. It also necessitates assessing lung volumes, as conditions like emphysema can increase lung volumes but decrease the alveolar capillary surface area, thereby lowering DLCO. Furthermore, evaluating the integrity of the alveolar capillary membrane is crucial. Conditions like pulmonary fibrosis or edema directly impair gas exchange across this barrier. This comprehensive evaluation aligns with the professional responsibility to provide accurate diagnostic data, as mandated by professional practice standards that emphasize thoroughness and the consideration of all relevant physiological determinants of test results. An incorrect approach would be to solely focus on the DLCO value without considering the patient's hemoglobin. This fails to account for the direct physiological relationship between hemoglobin and oxygen carrying capacity, leading to a potentially misleading interpretation. Regulatory guidelines for pulmonary function testing emphasize the importance of reporting all relevant patient data that influences test interpretation, and omitting hemoglobin would be a failure to adhere to this standard. Another incorrect approach would be to attribute a low DLCO solely to a problem with the alveolar capillary membrane, without investigating other contributing factors like lung volumes. For instance, a patient with severe emphysema might have a reduced DLCO due to increased lung volume and destruction of alveolar walls, not necessarily a primary membrane issue. Failing to consider lung volumes represents an incomplete physiological assessment and a deviation from best practices in pulmonary function interpretation. A further incorrect approach would be to dismiss a low DLCO as an artifact without a systematic investigation of potential physiological causes. While artifacts can occur, a technologist has a professional obligation to rule out physiological explanations first, especially when the patient's clinical presentation might be consistent with impaired gas exchange. This approach prioritizes expediency over diagnostic accuracy and patient care. The professional decision-making process for similar situations should involve a systematic review of the DLCO, result in conjunction with all available patient data, including hemoglobin, lung volumes, and clinical history. This iterative process of hypothesis generation and testing, guided by physiological principles and regulatory requirements for accurate reporting, ensures that the interpretation is robust and clinically useful. Question 10. Analysis of a patient's spirometry results reveals a forced expiratory volume in 1 second FEV1 of 65% of predicted and a forced vital capacity FVC of 80% of predicted. The FEV1/FVC ratio is calculated to be 0.70. Based on these findings and the established criteria for classifying lung diseases, which interpretation most accurately reflects the likely underlying pulmonary condition? Option A. The reduced FEV1/FVC ratio suggests airflow obstruction, and the reduced FEV1 relative to predicted further supports this. Option B. The FEV1 is reduced, but the FVC is relatively preserved, suggesting a mixed pattern of obstruction and restriction. Option C. The reduced FVC relative to predicted indicates a restrictive process, and the FEV1 is also reduced due to this restriction. Option D. The FEV1/FVC ratio is within the normal range, indicating no significant obstructive or restrictive disease. Correct answer is A. The reduced FEV1/FVC ratio suggests airflow obstruction, and the reduced FEV1 relative to predicted further supports this. Explanation. This scenario is professionally challenging because accurately interpreting the FEV1/FVC ratio is fundamental to diagnosing and differentiating between obstructive and restrictive lung diseases, which have distinct management pathways. Misinterpretation can lead to incorrect diagnoses, delayed or inappropriate treatment, and potentially adverse patient outcomes. The Registered Pulmonary Function Technologist, RPFT, has a critical role in ensuring the accuracy and appropriate clinical application of these measurements, adhering strictly to established guidelines. The correct approach involves understanding that a reduced FEV1/FVC ratio, typically below the lower limit of normal LLN, is the primary indicator of airflow obstruction. This ratio is a key component in classifying obstructive lung diseases like COPD and asthma. Conversely, a normal or increased FEV1/FVC ratio, coupled with reduced lung volumes, like FVC and TLC, suggests a restrictive pattern. The RPFT must be able to identify these patterns based on the provided spirometry data and relevant reference standards, without solely relying on absolute FEV1 or FVC values. This aligns with the professional responsibility to provide accurate and clinically relevant data that supports appropriate medical decision-making, as expected within the scope of practice for an RPFT. An incorrect approach would be to focus solely on the absolute FEV1 value without considering its relationship to FVC. For example, interpreting a low FEV1 as definitively obstructive without assessing the FEV1/FVC ratio fails to account for restrictive processes that can also lead to reduced FEV1 due to decreased lung volumes. This overlooks a critical diagnostic criterion and can lead to misclassification. Another incorrect approach would be to interpret a low FVC as solely indicative of restriction without evaluating the FEV1/FVC ratio. A low FVC can occur in both obstructive and restrictive diseases, making the ratio essential for differentiation. Relying on a single parameter or an incomplete assessment violates the principle of comprehensive data interpretation required for accurate pulmonary function testing. Professionals should employ a decision-making framework that prioritizes a systematic evaluation of spirometry results. This involves first assessing the FEV1/FVC ratio against established LLN values. If the ratio is reduced, it points towards obstruction. Subsequently, lung volumes TLC, FRC, RV should be examined. If lung volumes are reduced, it suggests a restrictive component, and the pattern is then classified as obstructive with restriction, or purely obstructive if volumes are normal. If the FEV1/FVC ratio is normal or elevated, and lung volumes are reduced, it strongly indicates a restrictive pattern. This structured approach ensures all relevant parameters are considered, leading to accurate classification and supporting appropriate clinical management. Question 11. The assessment process reveals an elevated airway resistance measurement during spirometry. Which of the following interpretations best reflects a comprehensive and clinically relevant approach for an RPFT? Option A. The elevated airway resistance should be interpreted in conjunction with the patient's symptoms, medical history, and other pulmonary function parameters to determine the most likely cause. Option B. The elevated airway resistance suggests a potential issue with the spirometry equipment and warrants a repeat maneuver with careful observation of patient effort. Option C. The elevated airway resistance is a normal finding in patients with a history of smoking and requires no further investigation. Option D. The elevated airway resistance definitively indicates intrinsic airway disease requiring immediate pharmacological intervention. The correct answer is D. The elevated airway resistance definitively indicates intrinsic airway disease requiring immediate pharmacological intervention. Explanation. This scenario presents a professional challenge because accurately differentiating between intrinsic airway resistance and extrinsic factors affecting airflow is crucial for appropriate patient management and diagnosis. Misinterpreting these findings can lead to incorrect treatment strategies, potentially worsening the patient's condition or delaying effective intervention. Careful judgment is required to synthesize objective data with clinical context. The correct approach involves a comprehensive evaluation of airway resistance measurements in conjunction with the patient's clinical presentation and history. This approach aligns with the ethical obligation of the Registered Pulmonary Function Technologist, RPFT, to provide accurate and clinically relevant data. Regulatory guidelines emphasize the importance of a holistic assessment, ensuring that diagnostic findings are interpreted within the broader patient context. This includes considering factors such as patient positioning, effort, and potential equipment artifacts that could influence resistance measurements, as well as correlating these with signs and symptoms of airway obstruction. An incorrect approach that focuses solely on the raw numerical value of airway resistance, without considering the patient's clinical status, fails to meet the standard of care. This oversight can lead to misdiagnosis, as elevated resistance might be a transient artifact rather than a true physiological change. Another incorrect approach that attributes all elevated resistance to intrinsic airway disease without exploring extrinsic factors, such as external compression or patient cooperation, is also professionally unacceptable. This demonstrates a failure to conduct a thorough differential analysis, which is a core competency for an RPFT. Professionals should employ a decision-making framework that prioritizes data integration and critical thinking. This involves first reviewing the raw data for quality control, then comparing it to established normative values, and critically, correlating these findings with the patient's history, physical examination, and other relevant diagnostic information. When discrepancies arise, further investigation or consultation with a physician is warranted to ensure the most accurate interpretation and subsequent patient care. Question 12. The evaluation methodology shows a patient with suspected chronic obstructive pulmonary disease undergoing pulmonary function testing. To accurately assess for air trapping and hyperinflation, which of the following approaches would be most appropriate and aligned with established professional standards for a registered pulmonary function technologist? Option A. Measuring total lung capacity TLC and residual volume RV using body plethysmography. Option B. Assessing the diffusing capacity of the lungs for carbon monoxide DLCO. Option C. Relying solely on the forced expiratory volume in 1 second FEV1 and forced vital capacity FVC ratio from spirometry. Option D. Performing a methacholine challenge test to assess airway hyperresponsiveness. The correct answer is A. Measuring total lung capacity TLC and residual volume RV using body plethysmography. Explanation. The evaluation methodology shows a patient presenting with symptoms suggestive of obstructive lung disease, necessitating a thorough assessment for air trapping and hyperinflation. This scenario is professionally challenging because accurately quantifying these phenomena is crucial for diagnosis, treatment planning, and monitoring disease progression. Misinterpretation can lead to inappropriate therapeutic interventions or a failure to recognize the severity of the patient's condition. Professional judgment is required to select the most appropriate and reliable methods for assessment, considering patient factors and the limitations of each technique. The correct approach involves utilizing plethysmography to measure thoracic gas volume, TGV, and residual volume, RV, which are direct measures of air trapping and hyperinflation. This method is considered the gold standard because it accounts for all gas within the thoracic cavity, including gas in communication with the airways, and is not influenced by patient effort or cooperation to the same extent as other methods. Regulatory guidelines for pulmonary function testing, such as those established by the American Thoracic Society (ATS) and the European Respiratory Society (ERS), emphasize the accuracy and reliability of plethysmography for these specific measurements. Adherence to these guidelines ensures that the assessment is performed according to established professional standards, leading to clinically meaningful and reproducible results. An incorrect approach would be to rely solely on spirometry to assess air trapping and hyperinflation. While spirometry can provide indirect indicators like a reduced FEV1/FVC ratio, it does not directly measure RV or TGV. Therefore, it cannot definitively quantify the extent of air trapping or hyperinflation. This failure to employ a method capable of direct measurement constitutes a deviation from best practice and regulatory expectations for a comprehensive assessment of these conditions. Another incorrect approach would be to use diffusion capacity, DLCO, as the primary method for assessing air trapping and hyperinflation. DLCO measures the transfer of gas across the alveolar capillary membrane and is primarily used to assess gas exchange efficiency. While hyperinflation can indirectly affect DLCO, it is not a direct or sensitive measure of air trapping itself. Relying on DLCO for this specific purpose would be a misapplication of the test and would fail to provide the necessary data for accurate diagnosis and management of air trapping and hyperinflation. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's clinical presentation, the specific diagnostic questions to be answered, and the available assessment tools. Professionals must be knowledgeable about the principles, advantages, and limitations of each pulmonary function testing modality. They should consult relevant professional guidelines and standards, e.g., ATS/ERS statements, to ensure that the chosen methodology aligns with current best practices and regulatory requirements for accurate and reliable patient assessment. Prioritizing methods that directly address the suspected physiological abnormalities, such as plethysmography for air trapping and hyperinflation, is paramount. Question 13. Research into the optimal measurement technique for assessing airway resistance in a pediatric patient experiencing significant anxiety and difficulty performing forced expiratory maneuvers, where initial attempts at body plethysmography have yielded inconsistent and unreliable results due to the patient's inability to pant effectively against the closed system. Option A. Discontinue pulmonary function testing immediately due to the patient's inability to cooperate. Option B. Transition to the forced oscillation technique, FOT, to assess airway resistance and reactance. Option C. Attempt to interpret the existing, albeit inconsistent, body plethysmography data, noting the limitations. Option D. Proceed with multiple repeat attempts of body plethysmography, coaching the patient extensively on panting technique. The correct answer is D. Proceed with multiple repeat attempts of body plethysmography, coaching the patient extensively on panting technique. Explanation. This scenario presents a common challenge in pulmonary function testing where a patient's ability to cooperate and the limitations of specific equipment can impact data quality and diagnostic accuracy. The professional challenge lies in selecting the most appropriate measurement technique when initial attempts yield suboptimal results, ensuring patient safety and adherence to established testing protocols. Careful judgment is required to balance the need for accurate data with the patient's comfort and physiological state, all within the scope of RPFT practice. The correct approach involves recognizing the limitations of body plethysmography in this specific patient presentation and transitioning to the forced oscillation technique, FOT. This is justified by the regulatory framework for RPFT, which emphasizes patient-centered care and the selection of appropriate diagnostic tools based on individual patient characteristics and test performance. FOT is a non-cooperative technique that can provide valuable information about airway resistance and reactance, even in patients who struggle with forced maneuvers. This aligns with the ethical obligation to obtain the best possible data while minimizing patient distress and avoiding potentially misleading results from a poorly performed body plethysmography. An incorrect approach would be to insist on repeating the body plethysmography multiple times without considering the patient's increasing distress and potential for bronchospasm. This disregards the patient's well-being and could lead to inaccurate or uninterpretable data, violating the principle of providing safe and effective care. Another incorrect approach would be to abandon the testing altogether without attempting an alternative, validated technique. This fails to meet the professional responsibility to obtain as much diagnostic information as possible within safe parameters. Finally, attempting to interpret the suboptimal body plethysmography data as representative of the patient's true pulmonary function would be a significant ethical and professional failure, as it would lead to misdiagnosis and inappropriate treatment. Professional decision-making in such situations requires a systematic approach. First, assess the patient's condition and ability to perform the requested maneuver. Second, evaluate the limitations of the current technique in light of the patient's presentation. Third, consider alternative, validated techniques that are suitable for the patient's condition. Fourth, communicate with the patient and the referring physician about the challenges encountered and the rationale for any changes in testing strategy. This ensures that the testing process is both clinically sound and ethically responsible. Question 14. System analysis indicates that a patient scheduled for body plethysmography is expressing significant anxiety and claustrophobia regarding the enclosed space of the plethysmograph. The registered pulmonary function technologist, RPFT, must determine the most appropriate course of action to ensure both patient safety and the integrity of the pulmonary function data. Which of the following approaches best aligns with professional standards and regulatory expectations for this situation? Option A. Proceed with the test as scheduled, providing minimal reassurance and focusing solely on completing the measurement quickly to minimize the patient's exposure time. Option B. Insist that the patient complete the full test without interruption, explaining that cooperation is mandatory for accurate results and that their discomfort is secondary to the diagnostic requirement. Option C. Immediately terminate the test and reschedule, advising the patient to seek medical consultation for their anxiety before attempting the test again. Option D. Implement a comprehensive strategy involving thorough patient education, gradual acclimatization to the plethysmograph environment, continuous verbal reassurance during the test, and readiness to pause or terminate if distress becomes unmanageable. The correct answer is A. Proceed with the test as scheduled, providing minimal reassurance and focusing solely on completing the measurement quickly to minimize the patient's exposure time. Explanation. Scenario analysis. This scenario presents a common implementation challenge in body plethysmography, ensuring accurate measurement of thoracic gas volume, TGV, and airway resistance, RAW, when a patient exhibits significant anxiety and claustrophobia. The challenge lies in balancing the need for a technically sound and interpretable test with the patient's well-being and ability to cooperate. Failure to address patient comfort can lead to unreliable data, necessitating repeat testing and potentially increasing patient distress. The RPFT must employ a systematic approach that prioritizes patient safety and data integrity within the established professional and regulatory standards. Correct approach analysis. The correct approach involves a multifaceted strategy that begins with thorough patient education and acclimatization to the plethysmograph. This includes explaining the procedure in simple terms, demonstrating the equipment, and allowing the patient to experience the environment without the door closed. During the test, the RPFT should provide continuous verbal reassurance and monitor the patient for signs of distress. If distress becomes significant, the RPFT should pause or terminate the test, reassess the patient's condition, and consider alternative strategies or rescheduling. This approach aligns with the ethical imperative to provide patient-centered care and the regulatory expectation of performing tests in a manner that ensures patient safety and yields valid results. The American Association for Respiratory Care (ARC) Clinical Practice Guidelines for Pulmonary Function Studies, which are foundational for RPFT practice in the U.S., emphasize patient cooperation and comfort as critical for obtaining accurate measurements. Incorrect approaches analysis. Forcing the patient to complete the test, despite clear signs of severe distress and claustrophobia, is ethically unacceptable and violates the principle of patient autonomy and non-maleficence. This approach risks causing significant psychological harm and will likely result in unusable data due to patient artifact, leading to wasted resources and further patient anxiety. It fails to meet the professional standard of care, which mandates adapting testing protocols to individual patient needs when possible. Ignoring the patient's stated discomfort and proceeding with the test without attempting any acclimatization or reassurance is also professionally negligent. This demonstrates a lack of empathy and a failure to recognize the impact of psychological factors on physiological measurements. Such an approach disregards the importance of patient cooperation, a cornerstone for obtaining valid plethysmography results, and contravenes the ARC guidelines that stress the need for a supportive testing environment. Attempting to complete the test quickly without adequate explanation or reassurance, while perhaps well-intentioned to minimize exposure time, is insufficient. While speed might seem beneficial, it does not address the root cause of the patient's anxiety. Without proper acclimatization and ongoing support, the patient's distress is likely to escalate, compromising data quality and potentially leading to a failed test. This approach lacks the comprehensive patient management required for successful plethysmography. Professional reasoning. Professionals faced with a claustrophobic or anxious patient during body plethysmography should first prioritize de-escalation and patient comfort. This involves a systematic process. 1. Patient education and preparation. Clearly explain the procedure, its purpose, and what the patient will experience. Use visual aids or demonstrations. 2. Acclimatization. Allow the patient to sit in the plethysmograph with the door open. Practice panting or breathing maneuvers and become familiar with the sounds. 3. Verbal reassurance and monitoring. Provide continuous calm and encouraging verbal cues throughout the test. Actively observe for signs of distress, e.g., rapid breathing, increased heart rate, verbal complaints. 4. Intervention and adaptation. If distress is observed, pause the test. Offer reassurance, a brief break, or re-explain the next steps. If distress is severe, consider terminating the test and rescheduling for a time when the patient might be more prepared or after consultation with their physician about potential anxiolytics. 5. Documentation. Accurately document the patient's condition, any interventions taken, and the reasons for test termination or modification. This structured approach ensures that patient safety and well-being are paramount while striving to obtain the most accurate and interpretable data possible, adhering to ethical principles and professional guidelines. Question 15. Comparative studies suggest that the interpretation of pulmonary function test results can be influenced by the choice of reference equations and the method used to define abnormality. A registered pulmonary function technologist, RPFT, is presented with spirometry data for a patient. The patient's forced expiratory volume in 1 second, FEV1, is 75% of predicted, but the calculated lower limit of normal LLN for this patient's FEV1 is 78% of predicted. Which of the following represents the most appropriate interpretation and subsequent action based on current RPFT practice guidelines and regulatory expectations? Option A. Interpret the FEV1 as abnormal because it falls below the lower limit of normal LLN. Option B. Consider the FEV1 as borderline and recommend repeating the test without further interpretation. Option C. Interpret the FEV1 as normal because it is above 70% of predicted. Option D. Adjust the predicted value upwards to account for the patient's perceived good effort. The correct answer is C. Interpret the FEV1 as normal because it is above 70% of predicted. Explanation. This scenario presents a common implementation challenge in pulmonary function testing, the variability of predicted values and the interpretation of results relative to the lower limit of normal LLN. The professional challenge lies in accurately applying these reference values to individual patient data, considering factors that might influence their applicability, and ensuring that diagnostic decisions are ethically sound and compliant with professional standards. Misinterpreting reference values can lead to misdiagnosis, inappropriate treatment, or delayed intervention, directly impacting patient care. The correct approach involves a nuanced understanding of how predicted values are derived and the significance of the LLN. It requires recognizing that predicted values are statistical averages and that individual variation exists. When interpreting a patient's pulmonary function test, PFT results, the technologist must consider the LLN as a critical threshold. A result falling below the LLN is generally considered abnormal, irrespective of its percentage of the predicted value. This approach aligns with the principles of accurate diagnostic testing and patient safety, as it prioritizes identifying potential pathology based on established clinical benchmarks. Regulatory guidelines for RPFT emphasize the importance of using appropriate reference equations and understanding their limitations, ensuring that diagnostic criteria are applied consistently and ethically. An incorrect approach would be to solely rely on the percentage of predicted value without considering the LLN. For instance, a result that is 70% of predicted might be considered normal by some older criteria, but if it falls below the LLN for that specific test, it should be flagged as abnormal. This failure to incorporate the LLN as a primary determinant of abnormality is a significant ethical and regulatory lapse, as it can lead to underdiagnosis of lung disease. Another incorrect approach is to arbitrarily adjust predicted values based on perceived patient characteristics without a validated rationale or established protocol. This introduces subjectivity and bias into the interpretation process, undermining the objectivity and reliability of PFT results and violating professional standards of practice that demand adherence to validated methodologies. Professionals should approach this by first ensuring they are using the most current and appropriate reference equations for the patient's demographics, age, sex, height, ethnicity, if applicable and supported by the chosen equation. Second, they must understand the statistical basis of the LLN and its role in defining abnormality. Third, when interpreting results, the LLN should be the primary determinant of whether a value is considered outside the normal range. If a result is below the LLN, it warrants further investigation and clinical correlation, even if it appears to be a reasonable percentage of the predicted value. This systematic, evidence-based approach ensures that diagnostic decisions are robust, ethical, and compliant with the standards expected of a registered pulmonary function technologist. Question 16. Operational review demonstrates that a registered pulmonary function technologist, RPFT, is preparing to administer a methacholine challenge test to a patient with a history of asthma. The patient reports experiencing mild shortness of breath at rest, but denies any recent exacerbations. The RPFT has access to the methacholine solution and spirometry equipment. Which of the following actions is most critical to ensure patient safety and the integrity of the diagnostic test according to established RPFT practice guidelines? Option A. Administer the initial dose of methacholine and closely monitor for any changes in the patient's forced expiratory volume in 1 second, FEV1. Option B. Administer a higher initial dose of methacholine to expedite the diagnostic process, given the patient's reported mild symptoms. Option C. Immediately proceed with the full protocol of methacholine administration as the patient's symptoms are mild and the test is indicated for diagnosis. Option D. Conduct a thorough pretest assessment, including a review of the patient's medical history for contraindications and current medication use, and ensure emergency equipment is readily accessible. Correct answer is A. Administer the initial dose of methacholine and closely monitor for any changes in the patient's forced expiratory volume in 1 second, FEV1. Explanation. This scenario presents a professional challenge because it requires the registered pulmonary function technologist, RPFT, to balance the diagnostic necessity of a methacholine challenge test with the paramount ethical and regulatory obligation to ensure patient safety. The administration of potent bronchoconstrictors necessitates meticulous adherence to established protocols to prevent adverse events, such as severe bronchospasm, and to ensure the accuracy and reliability of the test results. The RPFT must possess a comprehensive understanding of the drug's effects, potential contraindications, emergency preparedness, and the specific guidelines governing such procedures. The correct approach involves a thorough pretest assessment of the patient's medical history, including any known contraindications to methacholine or histamine, and a review of current medications that might affect airway reactivity. This is followed by strict adherence to the established protocol for methacholine administration, including precise dose increments, accurate measurement of spirometry at each interval, and continuous patient monitoring for symptoms and objective changes in lung function. Crucially, The RPFT must be prepared to immediately discontinue the test and initiate appropriate management if significant bronchoconstriction occurs, as per institutional policy and regulatory guidelines. This approach aligns with the ethical principles of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm, and is mandated by regulatory frameworks that emphasize patient safety and standardized testing procedures for diagnostic accuracy. An incorrect approach would be to proceed with the methacholine challenge without a comprehensive review of the patient's medical history, potentially overlooking a contraindication that could lead to a severe adverse reaction. This failure to conduct a thorough pretest assessment violates the principle of non-maleficence and disregards regulatory requirements for patient screening. Another incorrect approach would be to administer methacholine without precise adherence to the established dose increments and spirometry measurement intervals, leading to unreliable results and potentially missing critical diagnostic information or administering an inappropriate dose. This deviates from standardized protocols, compromising test validity and patient safety. Furthermore, failing to have emergency equipment and trained personnel readily available to manage a severe bronchospastic reaction is a critical ethical and regulatory failure, directly endangering the patient. The professional decision-making process for similar situations should begin with a thorough understanding of the specific diagnostic procedure and its associated risks. This involves consulting relevant professional guidelines and institutional policies, a systematic patient assessment, including a detailed history and review of contraindications, is the foundational step. If the patient is deemed a suitable candidate, the procedure must be executed with meticulous attention to detail, adhering strictly to established protocols for drug administration, physiological monitoring, and data recording. Continuous vigilance for any signs of adverse reactions and immediate, decisive action to mitigate risk are essential components of responsible practice. Question 17. Regulatory review indicates that during a spirometry maneuver, a registered pulmonary function technologist, RPFT, observes significant variability in the patient's expiratory effort across multiple attempts, despite clear instructions and encouragement. The patient expresses fatigue and difficulty in achieving maximal effort. The RPFT is concerned that the current data may not accurately reflect the patient's true pulmonary function. What is the most appropriate course of action for the RPFT? Option A. Immediately repeat the spirometry maneuver multiple times until a seemingly acceptable result is achieved, regardless of patient fatigue. Option B. Inform the patient that their effort is insufficient and terminate the testing session without further consultation. Option C. Proceed with reporting the obtained results without any qualification, assuming the patient's best effort was captured. Option D. Report the results with a clear notation to the ordering physician, detailing the observed variability in effort and the patient's expressed fatigue, recommending that the physician consider these factors in their interpretation. The correct answer is D. Report the results with a clear notation to the ordering physician, detailing the observed variability in effort and the patient's expressed fatigue, recommending that the physician consider these factors in their interpretation. Explanation. This scenario presents a professional challenge because it requires the registered pulmonary function technologist, RPFT, to balance patient autonomy and the desire to obtain accurate diagnostic data with the potential for misinterpretation of results due to external factors. The RPFT must exercise sound judgment and adhere to established ethical and regulatory guidelines to ensure patient well-being and the integrity of the testing process. The correct approach involves clearly and objectively communicating the observed variability in the patient's effort and its potential impact on the reliability of the results to the ordering physician. This approach upholds the principle of professional integrity by ensuring that the physician receives accurate and complete information for diagnosis and treatment planning. It also respects the patient's right to understand the limitations of their testing. Regulatory frameworks for allied health professionals, such as those governing RPFT, emphasize the importance of accurate reporting and professional communication with referring physicians. Ethical codes of conduct for healthcare professionals universally stress honesty, transparency, and the duty to provide the best possible care, which includes ensuring the validity of diagnostic data. An incorrect approach would be to proceed with reporting the results without any qualification, despite the recognized variability in patient effort. This failure to disclose potential limitations undermines the diagnostic accuracy and could lead to misdiagnosis or inappropriate treatment. It violates the ethical obligation to be truthful and transparent in reporting findings, and potentially contravenes regulatory requirements for accurate documentation and reporting of pulmonary function tests. Another incorrect approach would be to unilaterally decide to repeat the test without consulting the ordering physician, especially if the patient is experiencing discomfort or fatigue. While the intention might be to obtain better data, this action oversteps the RPFT scope of practice and bypasses the physician's authority in determining the necessity and appropriateness of further testing. This can lead to unnecessary patient burden and potentially conflict with established clinical protocols and physician-patient relationships, violating ethical principles of professional collaboration and patient advocacy. A third incorrect approach would be to dismiss the patient's concerns about their effort and proceed with the test as if no issues were present. This disregards the patient's subjective experience and the potential impact of their perceived effort on the objective measurements. It fails to acknowledge the human element in testing and can erode patient trust, violating ethical principles of patient-centered care and respect for individual experience. The professional decision-making process in such situations should involve a systematic evaluation of the situation, considering the patient's condition, the test objectives, potential confounding factors, and relevant regulatory and ethical guidelines. The RPFT should first attempt to optimize testing conditions and patient cooperation. If significant variability persists, clear, objective communication with the ordering physician is paramount, outlining the observed issues and their potential implications for the results. This collaborative approach ensures that the physician can make an informed decision regarding further actions, thereby safeguarding patient care and the integrity of the diagnostic process. Question 18. Consider a scenario where a patient undergoing spirometry exhibits an FEV1 measurement that is significantly lower than their previously recorded values, and the tracing shows a noticeable hesitation at the beginning of expiration. The technologist has performed 3 maneuvers, and while the FEV1 values are consistent with each other, they do not meet the criteria for an acceptable maneuver due to the initial hesitation. The technologist is aware of the patient's history of moderate persistent asthma. What is the most appropriate course of action? Option A. Report the FEV1 value that is closest to the patient's previous baseline, assuming the current lower value is due to a temporary exacerbation not reflected in the tracing. Option B. Re-instruct the patient on proper technique, emphasizing the importance of an immediate and forceful start to the exhalation, and attempt further maneuvers until at least 2 acceptable FEV1 values are obtained that are within 0.15 L of each other. Option C. Report the lowest FEV1 value obtained from the 3 consistent but technically flawed maneuvers, noting the hesitation in the report. Option D. Discontinue the test and report that a valid FEV1 could not be obtained due to patient noncompliance. The correct answer is C. Report the lowest FEV1 value obtained from the 3 consistent but technically flawed maneuvers, noting the hesitation in the report. Explanation. This scenario presents a professional challenge because it requires the registered pulmonary function technologist, RPFT, to go beyond simple data collection and apply critical judgment based on established guidelines. The challenge lies in recognizing when a measurement, even if technically obtained, may not accurately reflect the patient's true pulmonary function due to external factors, and understanding the implications of reporting potentially misleading data. Accurate FEV1 measurement is crucial for diagnosis, treatment monitoring, and research, and deviations from best practices can have significant clinical consequences. The correct approach involves recognizing the potential for artifact or patient effort variability to compromise the FEV1 measurement. This approach prioritizes the integrity and reliability of the data by ensuring that the recorded FEV1 is representative of the patient's maximal effort, and that the maneuver meets established quality standards. This aligns with the ethical obligation of the RPFT to provide accurate and trustworthy information to the healthcare team, as well as regulatory guidelines that emphasize the importance of quality control and adherence to standardized testing procedures to ensure patient safety and appropriate clinical decision-making. The RPFT role is to ensure the data is clinically meaningful. An incorrect approach would be to simply report the first FEV1 value obtained, regardless of its quality or reproducibility. This fails to uphold the professional responsibility to ensure data accuracy and could lead to misdiagnosis or inappropriate treatment. It disregards the established guidelines for pulmonary function testing that mandate multiple acceptable maneuvers and the selection of the best effort. Reporting a suboptimal FEV1 without proper qualification or retesting constitutes a failure to adhere to professional standards and potentially violates regulatory requirements for accurate patient assessment. Another incorrect approach would be to assume the patient is intentionally not cooperating and to terminate the test prematurely without attempting to troubleshoot or re-educate the patient on proper technique. This demonstrates a lack of patient-centered care and an unwillingness to adapt testing strategies to individual patient needs. It also bypasses the opportunity to obtain a valid FEV1 measurement, which is essential for clinical evaluation. A third incorrect approach would be to adjust the FEV1 value based on subjective interpretation of the patient's overall health status, without objective evidence from the test itself. This introduces bias into the reporting of results and deviates from the standardized interpretation protocols. The RPFT role is to objectively measure and report findings, not to speculate or alter data based on non-test-related observations. The professional decision-making process in such situations should involve a systematic evaluation of the test quality. This includes reviewing the FEV1 tracing for characteristic features of a valid maneuver, e.g., abrupt start, no hesitation, maximal expiration, no cough or glottis closure, and a plateau or continuous decline at the end of expiration. If the initial maneuver is suboptimal, the RPFT should employ strategies such as re-instruction, encouragement, and attempting further maneuvers to obtain a reproducible and valid FEV1. If, after repeated attempts, a satisfactory FEV1 cannot be obtained, the RPFT should document the reasons for the failure and report the best available data with appropriate caveats, rather than fabricating or arbitrarily adjusting a value. This process ensures that the reported FEV1 is both technically sound and clinically relevant, upholding the integrity of the pulmonary function assessment. Question 19. Strategic planning requires a technologist performing pulmonary function tests to critically evaluate the entire testing process to ensure accurate and reliable patient data. Which of the following approaches best reflects this strategic planning principle in the context of pulmonary function testing? Option A. Prioritizing the review of numerical results and immediately reporting them to the physician, assuming the testing process was inherently accurate. Option B. Focusing only on the most recent test results, disregarding previous testing sessions or trends. Option C. Relying solely on the automated quality control flags generated by the pulmonary function testing software without independent verification. Option D. Conducting a thorough review of the patient's effort, equipment calibration logs, and adherence to established testing protocols before finalizing any interpretation or reporting. The correct answer is A. Prioritizing the review of numerical results and immediately reporting them to the physician, assuming the testing process was inherently accurate. Explanation. Scenario analysis. This scenario presents a professional challenge in ensuring the accuracy and reliability of pulmonary function testing, PFT data, which directly impacts patient diagnosis and treatment. The technologist must navigate the complexities of equipment calibration, patient effort, and adherence to established protocols to produce clinically meaningful results. The challenge lies in maintaining a high standard of practice in a dynamic clinical environment where various factors can influence test outcomes. Careful judgment is required to identify and address potential sources of error, ensuring patient safety and the integrity of the diagnostic process. Correct approach analysis. The correct approach involves a systematic and thorough review of the patient's PFT results, considering all relevant factors. This includes verifying the quality of the patient's effort, ensuring the equipment was properly calibrated and maintained according to manufacturer guidelines and regulatory standards, and confirming that the testing procedure followed established protocols. This approach is correct because it aligns with the fundamental principles of PFT, emphasizing accuracy, reproducibility, and patient safety. Regulatory frameworks, such as those established by the National Board for Respiratory Care, NBRC, for RPFT certification, mandate adherence to best practices and ethical conduct, which includes ensuring the validity of test results. The American Thoracic Society (ATS) and European Respiratory Society (ERS) guidelines provide the scientific and technical basis for performing and interpreting PFTs, further supporting this comprehensive review process. Incorrect approach is analysis, an approach that focuses solely on the numerical values without considering the quality of the test or the patient's effort is incorrect. This fails to acknowledge that PFT results are only meaningful if the test was performed correctly and the patient provided maximal effort. Regulatory and ethical guidelines emphasize the importance of test quality indicators and patient cooperation. An approach that overlooks equipment calibration and maintenance is also incorrect. Faulty equipment can lead to systematically inaccurate readings, compromising the diagnostic value of the PFT. Adherence to calibration schedules and maintenance logs is a critical component of quality assurance in PFT, often stipulated by institutional policies and professional standards. An approach that assumes all tests are valid without critical review, particularly if there are any subtle indicators of suboptimal performance or unusual results, is professionally negligent. This bypasses the technologist's responsibility to critically evaluate data and identify potential issues that could lead to misdiagnosis. Professional responsibility, as outlined by certifying bodies and ethical codes, requires a proactive approach to ensuring data integrity. Professional reasoning. Professionals should employ a decision-making framework that prioritizes a systematic evaluation of all PFT components. This framework should include 1. Initial data review. Assess the raw data and graphical displays for obvious anomalies. 2. Quality assessment. Evaluate patient effort and adherence to instructions using established quality criteria. 3. Equipment verification. Confirm that the equipment was calibrated and functioning correctly. 4. Protocol adherence. Ensure the testing procedure followed current guidelines. 5. Clinical context integration. Consider the patient's history and clinical presentation in interpreting results. This structured approach ensures that all potential sources of error are addressed, leading to reliable and clinically useful PFT results. Upholding professional standards and patient well-being. Question 20. The investigation demonstrates a patient performing spirometry with a measured inspiratory capacity, IC, that is significantly lower than predicted, despite a normal forced vital capacity, FVC, and FEV1/FVC ratio. The patient reports mild dyspnea on exertion. Considering the RPFT role in ensuring accurate and interpretable pulmonary function data, which of the following actions best reflects professional responsibility in this scenario? Option A. Advise the patient to perform breathing exercises to improve their IC before repeating the test, as this is a common technique to enhance inspiratory muscle strength. Option B. Reevaluate the quality of the spirometry maneuver, specifically focusing on the patient's ability to achieve maximal inspiration from functional residual capacity, and consider the possibility of inspiratory muscle weakness or upper airway obstruction contributing to the reduced IC, then correlate findings with the reported dyspnea. Option C. Report the measured IC value as is, assuming the spirometry equipment is functioning correctly and the patient's effort was adequate, and await physician interpretation. Option D. Conclude that the reduced IC is an isolated finding unrelated to the patient's dyspnea, as other spirometric parameters are within normal limits, and proceed with reporting. The correct answer is C. Report the measured IC value as is, assuming the spirometry equipment is functioning correctly and the patient's effort was adequate, and await physician interpretation. Explanation. This scenario presents a professional challenge because the interpretation of inspiratory capacity IC is crucial for diagnosing and managing respiratory conditions, and deviations from expected values can significantly impact patient care decisions. The technologist must not only accurately measure IC, but also understand its implications within the broader context of pulmonary function testing and patient presentation, adhering strictly to established protocols and ethical guidelines. The correct approach involves accurately measuring IC according to standardized protocols, ensuring patient effort and technique are optimal, and then interpreting the result in conjunction with other spirometric parameters and the patient's clinical history. This aligns with the ethical obligation to provide accurate and reliable data for clinical decision-making, as mandated by professional standards and guidelines for pulmonary function testing. The Registered Pulmonary Function Technologist (RPFT) certification signifies competence in performing and interpreting these tests, requiring adherence to best practices that ensure patient safety and diagnostic integrity. An incorrect approach would be to solely focus on obtaining a single IC value without considering the quality of the maneuver or its relationship to other spirometric measures like forced vital capacity, FVC, and forced expiratory volume in 1 second, FEV1. This failure to integrate data and assess maneuver quality could lead to misinterpretation, potentially resulting in incorrect diagnoses or inappropriate treatment plans. Another incorrect approach would be to ignore the patient's reported symptoms or clinical context when interpreting the IC. Pulmonary function tests are tools to be used in conjunction with clinical information, and a technologist who fails to consider this holistic view is not acting in the best interest of the patient. Furthermore, deviating from established measurement and interpretation guidelines without a clear, documented rationale based on patient-specific needs or limitations would be professionally unsound, as it compromises the standardization and comparability of test results. Professional decision-making in such situations requires a systematic process. First, ensure the technical quality of the measurement through adherence to established protocols. Second, interpret the IC value in the context of other spirometric data and the patient's clinical presentation. And third, communicate findings clearly and accurately to the referring physician, highlighting any significant deviations or potential implications. This integrated approach ensures that the data generated is both technically sound and clinically relevant.